Hello, my name is Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GPnotebook study groups. Welcome to this GPnotebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. And you can find us wherever you get your podcasts, including Spotify, Apple Podcasts, and Google Podcasts. So do please follow us to receive notifications about new episodes. And if you like what you hear, and we really hope you do, please consider leaving a review to help other listeners find us. If you're on Twitter, you can follow us there at GPnotebook for more information about new podcast episodes and study groups. And you can visit GPnotebook.com for podcast episode show notes and to find out more about upcoming study group meetings. Now, in this episode, I wanted to discuss irritable bowel syndrome, or IBS, a chronic functional gastrointestinal disorder which presents with abdominal pain and altered bowel habits. Now, as we all know, it affects about 20% of the general population at any one time, and so is a huge part of our primary care workload. It's more common in women and has a considerable impact on the quality of life and healthcare costs in general. Now, its clinical presentation can be typically characterized by abdominal pain associated with the change in stool frequency or form in the absence of any organic disease. Now, there's a vast range of literature on IBS, and this continues to expand as we learn more about this common condition, but there are essentially 4 different entities of IBS that have currently been identified according to the Rome 4 criteria. And these are IBS with constipation, or IBS-C, IBS with diarrhea, IBS-D, IBS with a mixed pattern of constipation and diarrhea, that's IBS-M, and finally unclassified IBS. And these subgroups of IBS are reflected by stool appearance, evaluated according to the Bristol Stool Form Scale on days with at least one abnormal bowel movement. Now, in IBS-D, at least 25% of bowel movements present with BSF scale 6 or 7, and less than 25% are BSF 1 or 2. In IBS-C, about 25% of bowel movements at least are present with BSF 1 or 2, and less than 25% are BSF 6 or 7. In other words, the reverse, IBS-D. In IBS-M, more than 25% of bowel movements can be classified as BSF 1 or 2, and more than 25% are BSF 6 or 7. Patients with unclassified IBS meet the criteria for irritable bowel syndrome, but their pattern of bowel movements can't be assigned into any of the previous 3 categories. Now, although the exact cause of IBS still remains unclear to us, it is well known to have a multi-factorial nature. And IBS is traditionally considered part of the so-called brain-gut disorders, along with other functional gastrointestinal diseases, and some studies do suggest that patients with IBS can have abnormal serotonin and dopamine secretion, with both the degree and proportion of these alterations playing a role in determining the clinical pattern of the disease in individual patients. Some patients with IBS may also have increased intestinal membrane permeability and hypersensitivity to somatic and visceral stimuli. This leads to altered perception, whereas others may have intestinal dysmotility related to dysregulation of the 5-hydroxytryptamine pathway. Now, much work is also currently being done on small intestine bacterial overgrowth, as this does appear to be prevalent in IBS, but the causal and temporal relationship between these 2 conditions still remains unclear. Now, about 10% of patients who develop IBS have a previous history of enteric infections, and between 3 to 36% of cases of gastroenteritis are followed by persistent IBS symptoms, the so-called post-infective IBS. Interestingly, food allergies among patients with IBS are actually quite rare, but intolerances, on the other hand, are quite common. And this means that poorly absorbed carbohydrates can increase bowel fermentation and so trigger IBS symptoms in people with gut hypersensitivity. Now, of course, we must never forget the important role of psychosocial factors in IBS, reflected by the very well-known association between IBS and psychological disorders, typically things like anxiety or depression. And in fact, IBS symptoms are worsened by psychological distress, and in turn, abdominal pain and changes in bowel habits can then worsen symptoms of anxiety and depression. Now, when we're making a diagnosis of IBS, NICE currently suggests the following criteria, which is that patients must give at least a 6-month history of either abdominal pain or discomfort, bloating, or a change in bowel habit. And I find the ABC mnemonic can quite be a useful aid memoir here. Abdominal pain for A, bloating for B, and change in bowel habit for C. Consider positively diagnosing IBS only if this abdominal pain is either relieved by defecation or associated with altered bowel frequency or stool form, and at least 2 of the following 4 are present. 1. Altered passage of stool, by which I mean straining or urgency or incomplete evacuation. 2. Abdominal bloating, distension, tension or hardness. 3. The symptoms are aggravated by eating. And 4. Occasional passage of rectal mucus. Lethargy, nausea, backache, and even bladder symptoms may also be used to support a diagnosis of IBS. Now, the onset of symptoms must occur at least 6 months before the diagnosis, as I say, and exclusion of any organic cause of the symptoms requires taking a detailed medical history and physical examination with special attention to red flag symptoms. And this includes blood in the stools, unexplained anemia, unintentional weight loss, fever, nocturnal symptoms, and the onset of symptoms for the first time after the age of 50. In fact, one of my messages from the wayside pulpit here, after 40 years in the NHS, is to always think twice and then twice more before making any diagnosis of IBS in someone over the age of 50 presenting with symptoms for the first time. Medical defense case reviews are full of doctors who have fallen into that particular dangerous trap. And it should go without saying that an urgent 2-week referral is appropriate if signs and symptoms of cancer are present, in line with NICE guidance on recognition and referral for suspected cancer. If you've got a patient who does meet the symptomatic criteria for IBS, then I would suggest investigation should include a full blood count, ESR and CRP as inflammatory markers, antibody testing for celiac disease, a CA125 for women with symptoms, which could be ovarian cancer, and do remember that the bloating of IBS is typically fluctuating, whereas it is not in ovarian cancer. And I would also suggest a fecal calprotectin for those with symptoms that could be inflammatory bowel disease. So once you've confidently made a diagnosis of IBS, then lifestyle interventions such as dietary modifications, physical activity, and stress reduction are the most important non-pharmacological clinical approach for a patient with IBS. Now, the British Society of Gastroenterology guidelines highlight that dietary advice should be considered as a first-line approach. So traditional dietary advice recommended by NICE for patients with IBS include a regular pattern of meals, the avoidance of large meals or skipping meals, a fluid intake of around 2 litres a day with limited consumption of alcohol or fizzy drinks, and reduced intake of fat, insoluble fibre, caffeine, and gas-producing food such as fresh fruit. Now, fermentable oligosaccharides, disaccharides, monosaccharides, and polyols, known as FODMAPs, such as fructans, galactans, lactose, fructose, sorbitol, xylitol, and mannitol, can all induce bowel fermentation, and this can increase pain and flatulence. So dietary restriction of FODMAPs, the so-called low FODMAP diet, may help to relieve these symptoms, and there is some evidence to support this approach, with up to 80% of people with IBS being said to report an improvement in their symptoms when using a low FODMAP diet, specifically bloating, abdominal pain, flatus, and altered bowel habit. The role of lactose intolerance in IBS is currently controversial. Compared to the general population, patients with IBS more often report symptoms related to lactose malabsorption despite similar rates of hydrogen positivity on breath tests. But, in my clinical experience at least, in some IBS patients, a reduced lactose intake may indeed reduce their symptoms. And similarly, some patients with IBS report abdominal symptoms following gluten ingestion in the absence of any known celiac disease. And this may be linked to poorly absorbable carbohydrates rather than gluten itself, or to a degree of non-celiac gluten sensitivity. Now, there's much interest at the moment as to whether probiotics could be helpful in treating IBS symptoms. And as a general point, multi-strain probiotic supplements seem better than mono-strain supplements, but there's insufficient quality evidence at present to make specific recommendations about these. NICE guidelines do suggest that if these are used, they should be taken for 4 weeks at the dose recommended by the manufacturer, whilst monitoring for any possible beneficial or adverse effects. Now, if we're looking at pharmacological treatment in IBS, never underestimate the strong potential placebo effect and aim to target individual symptoms such as diarrhea or abdominal spasm, bloating, or constipation. Now, if diarrhea is the main symptom, then loperamide is often the medication of choice here, and if there's abdominal pain and spasm, then always try antispasmodics such as Alvarin, Mebeverin, or peppermint oil, which have a good safety profile. If constipation is the key symptom, then a laxative of choice may be used, but I would always avoid lactulose, and linaclotide has recently been added as an option here when other laxatives haven't worked and constipation has been present for 12 months. I'd also always follow up patients after 3 months on any kind of anti-constipation treatment. I think we all know that in some patients with IBS, antidepressants can be of benefit, with both tricyclic antidepressants and SSRIs being shown to be effective, with NICE guidelines suggesting the use of an SSRI only if a low-dose tricyclic hasn't been effective. So treatment should be started with a low dose such as 10 milligrams of amitriptyline, for example, and increase if necessary to no more than 30 milligrams. Now, globally, drugs such as 5-hydroxytryptamine 3 receptor antagonists, 5-hydroxytryptamine 4 partial agonists, and chloride channel activators are all being trialled and used in IBS-C and IBS-D, but are currently unavailable in the UK. but it is worth mentioning eloxadiolene here, a mixed opioid receptor drug that's becoming available in NHS secondary care for the treatment of patients with IBS-D. Now, this works by binding to specific receptors in the digestive system and slowing down the passage of food through the gut, relieving stomach cramps and the urgent need to open the bowels, and it may be given alongside existing therapies for IBS-D. Just worth mentioning, it's contraindicated in patients with prior sphincter of Oddi problems or cholecystectomy, alcohol dependence, pancreatitis, or severe liver impairment. Now, when we're looking at IBS prognosis, as we all, I think, know, this is highly variable, with symptoms typically fluctuating over many years, and over half all IBS patients still report being symptomatic 7 years after their initial presentation. People with a long history of IBS are less likely to improve, and it's little surprise, I suspect, that ongoing stress may slow down any recovery. So that's a brief overview of irritable bowel syndrome, and I do hope you found it helpful, but have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you have any questions, comments or ideas for future podcasts. You can also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round, and also to download free shortcuts to help improve the lives of our patients in primary care. But, as always, until the next time, thank you for listening, and goodbye.